Thank you for having me here again. My name is Dr. Gary Palak. I won't introduce myself because Prab already did such a great job, but I'm here to talk about essential assessments of a pain examination. I think we were talking about, if anyone has any questions, like in between the presentation, just put your hand up, stop me, ask a question. There's no point sitting for 30 minutes not really understanding or getting hung up on a point. So feel free to stop me if you have any questions about what I'm saying. So what we're going to talk about is quickly go over what's involved in a comprehensive pain visit checklist, review warning flags, pain assessment tools, physical examination, and approach to treatment. So a comprehensive pain visit checklist, this is what my checklist involves. So when I see a pain patient in consultation, the first thing I'm going to do is obviously a history and physical examination. Then from that, I'm going to try and figure out what type of pain am I dealing with. Is it mostly nociceptive pain? Is it neuropathic pain? Is it nociplastic? And then I ask myself, are there any contextual factors that I need to consider? And this is when we get into things like yellow flags and orange flags. And then what's my differential and what investigations do I need to do? And then I ask myself, how am I going to approach treatment? So, with what we learn in medical school and what we learn in residency, it's all about the biopsychosocial approach, right? What component of it is biological? Are there any social factors? Are there any psychological factors? And we take this into account not just for treatment, but also in my assessment. So the first part of the assessment, the biological piece, that's the history and physical examination. And so I'm not going to stand up here and tell you how to do a back exam or a neurological exam, but I want to draw your attention to two important things. The first is the clinically orientated relevant exam, or the core back tool, which is available online. And then the second thing I just want to remind you is just the importance of dermatomes, because sometimes I think people forget how important dermatomes are when you're making a referral and whether you're assessing if someone's pain is radicular or not. So this is available online. It's a 2 or 3 page PDF that you can download. And so it will go down sections of history and physical examination, and even categorizing or diagnosing back pain, and then prescribing the appropriate exercises to your patient. And you can do this with this tool. So the first question is to ask, does this patient have back dominant or leg dominant pain? From there, the next question you're going to ask is it constant or intermittent? And then whether any movement such as flexion, extension, walking or standing will provoke their pain. And then based off of those few questions, you're going to be able to categorize their pain as pattern 1, pattern 2, pattern 3, pattern 4, right? So we're looking at discogenic pain, facet-mediated pain, radicular pain, and then spinal stenosis. Along with the core back tool, they also include a sample physical examination to consider. So when I work with residents and they're doing a history and physical examination on a patient, right, and they come back and say, oh, the patient's got back pain and it goes down their leg, right? The important thing is to try and figure out where down their leg or where in their arm they're having those pain symptoms, right? Although these dermatomes are not as cleanly as they're shown here in this diagram, they typically follow this pattern, right? And so if someone has pain from their back that goes out across their hip, down the side of your thigh, side of the leg, on top of the foot, there's a very good chance that's an L5 dermatomal pattern, right? And then before you even order your MRI, you're going to be writing on there, pain in the L5 distribution, please assess, right? Because oftentimes we'll get referrals to our clinic that'll say, neck pain or back pain radiating down the limb. And then when you trace it out, it doesn't follow any one of these patterns. And it ends up being something completely different, like a hip joint or an SI joint or something else. And just a part of my physical examination, when I see back pain, I also include a sacroiliac joint exam and a hip exam. And I just wanted to include the fibromyalgia guidelines. These have been out for a few years now, but I wanted to highlight the importance of this isn't a diagnosis of exclusion. So if you're seeing a patient with widespread pain, You can fill out this questionnaire or fill out part 1 and then give them part 2 to fill out on their own. And then with this, you can come up with the diagnosis of fibromyalgia. So, warning flags. So we all know what red flags are, right? From medical school, we've heard of them, we've seen them, we get worried about them. So cauda-equina syndrome, fractures, tumors, nighttime pain, weight loss that's unprovoked, incontinence, saddle anesthesia. When we deal with chronic pain, we also look at orange flags, yellow flags, blue flags, black flags. So, orange flags. Orange flags are performed by asking questions regarding depression, anxiety, so mood disorders. We're asking about personality disorders. And so some people use screening questionnaires, some people don't. You have the option for PHQ-2 if you want, right? And then also I include in orange flags trauma history, right? So I always feel that if you're going to ask a sort of a history or you're going to ask any questions around trauma, if you're going to unbox something, you got to be able to put it back in the box, right? And so I'm not trained to do that. And so normally the way that I phrase or ask about trauma history is I usually ask, like, do you have kids? And then I ask, was there things that happened in your childhood that you don't want your kids to experience, right? Or there are things in your childhood that were sad or upsetting. And if they say yes, then I leave it at that and I just make a note, right? This person might need counseling around their trauma, right? Okay, so yellow flags. Yellow flags are more not so much around mood issues, but they're more about thoughts and feelings and behaviors, right? So common examples: catastrophizing, thinking that this is the worst, right? You might have yellow flags if your patient, I don't want to use the word freak out, but has an exaggerated reaction to like uncomfortable procedures, like a blood draw, right? They have unhelpful beliefs about their pain. Oh no, I can't go back to work, it's going to make my pain worse. No, I can't go to physio because they're going to ask me to do lifting and I can't lift, I'm going to make my back worse. They might be over anxious, they might be preoccupied with their health. They might have a fear of movement or re-injury, and that's called kinesiophobia. If they have a lot of uncertainty, they might have rumination behaviors, right? Or if they're overly passive and they're expecting someone else to come with a pill or a needle to try and take away all their pain. So some of your patients that you might encounter might have some yellow flags. Blue flags are probably something you haven't heard about. The blue flags are considered in terms of the employee and the workplace, all right? So sometimes the employee has fears or misconceptions about work and health based on previous experiences of other people, or just their history with the company. So blue flags could include, concerns about whether the person's going to be able to meet the demands when they go back to work. They might have low job satisfaction, or little or poor support at work. So sometimes employers might not offer or be able to offer gradual return to work programs or light duties, those sorts of things. There might be a perception on the employee's part or your patient's part that the job is very stressful and they might not be able to return. They might have difficulty accommodating the patient, and oftentimes there's poor communication between the employer and the employee. Black flags are very similar to blue flags, except you can consider blue flags as what's in the control of the person and their workplace. Black flags are considered outside of that. And the big one is if there's a WCB involved or ICBC, right? So any sort of insurance claim, if there's any sort of means of sort of financial gain, right? That's where you get a lot of black flags coming up. Right. But the next section is pain assessment tools, and sort of everyone has their own tools that they use to diagnose or assess or screen for things. These are the ones that I use. If you have your own, feel free to keep them. But as long as you feel comfortable, and I say at least have one tool for For anxiety, I like to use the GAD-7, right? For depression, I like to use PHQ-9. I'm familiar with it. It's easy to administer. It's very quick for me to score. PTSD, I use PCL-5. For pain catastrophizing, I use the pain catastrophizing scale. And then for kinesiophobia, the Tampa scale for kinesiophobia. For sleep, I like to use 2 questionnaires. One is the pain and sleep questionnaire, which is a nice three question questionnaire. And then I also use the STOP BANG acronym for sleep apnea. Something that I'm starting to use now that I didn't really use before is looking at injustice. Because oftentimes, especially people that have had like workplace injuries or motor vehicle collisions, and either they weren't believed by the emergency room physician, or their employer doesn't believe them that they're injured, or the case manager at the insurance company doesn't believe them, they often have a high amount of injustice. Right? So this is a great way to screen for it, and then you can target your interventions to that. So just for imaging, I get this a lot when I'm going through referrals. I'll see like x-rays once a year, every year that they've had pain. And so choosing wisely Canada suggests that you don't get serial x-rays unless things have changed. All right, there's no reason to do it. And then I only obtain MRIs in the setting of radicular pain and when there's red flags. So my approach to treatment. So the first thing I ask myself before I even jump into this is, what type of pain am I dealing with? What are they presenting with? Is it mostly nociceptive pain? Is it predominantly neuropathic pain? Or is it nociceptive neuropathic nociplastic? Is it mixed? Does this person have a combination of nociceptive and neuropathic pain? Or was their pain initially neuropathic and now it's become nociplastic? You know, I think once you can identify what type of pain they're having, then you can target your interventions a little bit more specifically. So getting back to this. So when I think about treatment and my approach to treatment, I think about the biological, the social, and the psychological. Sometimes you encounter patients and they have a huge biological component to their pain, right? They fell, landed on their knee is swollen, but otherwise, prior to this, they were functioning well. They didn't have anxiety or depression. They went to work, right? They were involved in their community. They had good social supports. These are people that respond really well to medications and interventions, right? The previous 2 sessions, there was a Slido question on emotional pain, right? And so it is possible that you could take someone who the majority of their pain is psychological, right? They might have a minor injury, but they might also have really high anxiety scores, really high depression scores, and their catastrophizing is through the roof. All they do is sit and ruminate about their pain, and they're afraid to move because they think they're going to make it worse, right? These people or these patients are not going to benefit from a needle, right? They're going to benefit from some medication. They're going to benefit from counseling, and they're going to benefit for some gentle, active re-engagement or active rehab. Does this slide make sense? Okay. So, just briefly, I'm not going to read out all the different medications that you can give somebody for pain, but from a biological perspective, treating people with pain. So there's options for medications. There's physiotherapy, chiropractic therapy, acupuncture, osteopath, active rehab, gentle range of motion to start off with. These people are going to respond well with interventions, surgery, bracing and orthotics, and potentially neuromodulation. When you're trying to deal with people that have more psychological symptoms, again, there are medications that you can use to help with mood, but they're going to benefit most with counseling, CBT, ACT, pain reprocessing therapy, mindfulness, biofeedback, and education. And so social treatments. So this was the hardest one. And this is the one where I kind of had to look things up. So how often do we ever prescribe social treatment for people? And the answer is probably not a lot. But we know social support acts as a buffer for neural stress. When a patient feels that they're being journeyed with, that their brain's perception of pain often shifts from a threat to something that's a challenge and should be overcome, right? And when I was reading this quote, I thought about one of my ex-girlfriends and how she would come to me with her problems, and I would say, well, this is how you fix your problems. Do this and do this and do this. Well, she didn't want the fix. She just wanted support. She wanted me to journey with her while she was telling me and going through her problems. So we know that social treatments can reduce stress related to pain, lowers psychological distress, and it boosts morale and it fosters a sense of community. And we can do this through support groups and online communities, right? So Pain BC, Foundations of Pain. Social prescribing is taking that person out of their home, out of their head, and putting them back into the community. Whether it's a book club, whether it's a gardening club, whether they had an interest in art or charity, it's getting them out of their house, doing something to shift their thoughts away from their pain into something they actually enjoy, right? I think prior to COVID, Pain BC was doing a lot of peer-to-peer mentoring and initiatives. And I'm not sure if Jim Pattison still has the alumni group up and running. They do, okay. Community pain program, yeah. Right, so this is where people with similar conditions can get together and they can talk about their pain. They can see people like themselves. Even you're having a bad day, somebody else in the group might be thriving, right? And it can help boost your morale, right? Interpersonal counseling and therapy, so family and couples counseling, right? We know that couples, family members can help with co-regulation, having or fostering an inclusive workplace, and this is where you can involve if you have access to a social worker. Last time I was here, there was a question on referrals and how to refer to me. So for the Lower Mainland, Initium Center for Pain Medicine, we're just outside we're just in Abbotsford, just off the McCallum exit by the Abbotsford Regional Hospital. My wait list was closed for a few months just because it started to get over 12 months long. So it's come down to under 12 months, so it's going to be reopening again. But if you do need to refer anybody, you've got Dr. McInnes, Dr. Chen, Dr. Bradford, and Dr. Wu. They're all still accepting referrals, and they're all excellent pain physicians. And then that's the end of my talk. Tom, yeah.
Thanks, Gary, for a good talk. I just found in dealing with chronic pain like neuropathic pain that it's important to set the goal of care. And the patients think that the goal of care is they're going to be pain-free. And yet, from our point of view, we know we're not going to get there first. And so, therefore, the goal of care can be shifted to increase function and have the patients aim for that, knowing that they can still have pain.
I'll just say, that's the music to physiatrist ears, right? Even as a pain physician, you know, there's so much of like, I ask patients, tell me about your pain, and the first thing they do is like, well, it's an 8 out of 10. It's like, no, I didn't ask for a number. It's like, just tell me about it, right? What I'm more concerned about is exactly what you said, just function, right? Are you able to do more than what you were able to do before? Is this medication helping? I didn't put it up there, but it probably should have been up there, but it's the importance of goal setting and setting the expectations early in the assessment in terms of, you know, you've had back pain for 25 years. The chance of you being completely pain-free from these interventions and treatments is very low, right? But if we can help to reduce your pain by 20% or 30%, what are you going to do with that? Right? And it's the same argument with medications. It's like, yes, we can start you on gabapentin and your pain can come down, say 30%, 40%, but then what are you doing? If it's like, well, if my life hasn't changed, if I'm still hanging out, watching TV, not really doing much, not going back to work, then, you know, what's the point? Yeah.
What are your preferences for people with pain on blood thinners?
So from,
Blood thinners.
but from like a medication perspective?
Yeah, what medication? Just recently I found out that there is so many seniors and they have pain, falls and pain and muscle and bone pain, but there is not too many medication we can offer them if they're on blood thinner, like for example an Eliquis blood thinner.
Yeah, no,
So
I,
what would be your preference to kind of recommend to these people? And besides
I was gonna say, I didn't know there was an issue with medications and blood thinners. The only one being anti-inflammatories.
Yeah, but what else you can give them? There's no non-steroidal anti-inflammatory we can offer them.
So-
Give them Tramadol. You cannot give them like this good painkillers and
Is there? Do you know of any issue with Tramadol and blood thinners?
I don't know of any contraindication to, so I'm not giving a talk on medication, but I'm just gonna be a pro for that. But like, generally the workhorses of pain medicine in terms of like chronic pain is gonna be SNRIs like duloxetine, gabapentinoids like pregabalin, and then the TCAs for your younger patients without cardiovascular risk factors, so like nortriptyline. And as far as I know, none of those have risk factors with anticoagulants. The only thing I would be concerned about, especially in elderly patients, if they're jacking up the gabapentin dose, they fall, right? Like that's the only concern I can think of.
Yeah.
Do you know of any contraindications or interactions?
Not that I'm aware of. Launette, do you know of any?
Well, it's just, your concern is non-steroidal anti-inflammatories.
Yeah.
And depends on what anticoagulant they're on and, or if the end, what you want to, if you're trying to use true aspirin with them. So, you just, take that into consideration, but you can use acetaminophen, as you mentioned, and then you can use the other categories.
but they are elderly, for example. Most of people on blood thinners, they will see elderly people,
Right.
and they I tried gabapentin, I tried like even T3, but they are getting dizzy, so much dizzy. It's a lot of
So it
side
depends on the
effects.
anticoagulant, but some you can use non-steroidal anti-inflammatories like ibuprofen and things. You can ask their stroke specialist who put them on to see what level they think is all right.
Anecdotally, I find duloxetine is best tolerated.
Yes.
Just it seems to be the one that it either works or it doesn't. But if it doesn't, it's not that bad as compared to like gabapentin. Some of the people are like, "Oh, I hate that," and then they get this bad taste in their mouth for medications. And so many patients are very hard on, like, "Nope, I don't do meds," and then you kind of lose them there. I like duloxetine.
I was going to say the only concern that I typically have with blood thinners was when it comes to interventions, right? So if I'm putting a needle in a spot in their spine or into a joint, that's when I get concerned about blood thinners. But usually I don't worry about blood thinners and medication. Yeah, sorry, except for anti-inflammatories. That's usually when I'm like, but even then I'll say if you use it a few times a week, is it going to be an issue? Probably not, but just be aware that there's a risk of GI bleeding.
So I'm a clinical pharmacist at the BCN. What I would say you have to be very careful about is using duloxetine with Eliquis.
Okay.
There is a greater chance that it can cause bleed. But it would depend on the individual, if they're elderly, what other medications they're taking, are they taking NSAIDs, what's their kidney function. So like they said, SSNRs can be used, like duloxetine could be used, you can use gabapentin, you can use Lyrica, lower doses. You do have to monitor the sodium levels. There can be increased falls, but it can be used, but you have to be very careful with that.
I give for one patient cyclobenzaprine, so he couldn't stand up for 3 days from the bed.
Yeah, I mean, unfortunately, cyclobenzaprine is really not indicated for.
Like a muscle relaxant.
Yeah, I mean, elderly are much more prone to side effects, so you have to really decrease the dosages and more non-pharmacological interventions.
Oh, good.
I was just going to say more non-pharmacological interventions would be beneficial for the elderly, because like you're dealing with a lot of like drugs that, especially the P450. So like I said, duloxetine can cause increased bleeding. Usually in a normal individual, this should not be a problem. But when you're dealing with elderly who are like chronic kidney disease, who have like low EFGRs, you really have to kind of like look at that. And I'm just sort of putting this out there as I'm the only pharmacist in the primary care network here in Surrey-North. So if you have and I deal with a lot of chronic pain, diabetes, high blood pressure, etc., you're more than welcome to make a referral. I will then reassess the patient and make some recommendations, and you will get a letter. And then you can then look at those recommendations and act upon them. I also do follow-up, so it's not like a one and done thing. I can follow patients up to a year or shorter, depending on what the situation is.
Can I just say one thing? There was a mention of cyclobenzaprine. It's not a true muscle relaxant, so that's a bit of a misnomer. It's called that, but if you, the studies that actually put electrode needles into the muscle to electrically record, it does not relax the muscle. The only true muscle relaxant is baclofen. So it is really a dirty drug, and we try to, in that sense, it has more cognitive effect than anything, so we usually try to take people off that. I usually discourage the use of cyclobenzaprine, especially in
Yes.
Recovering addict, in a recovering addict, how concerned you will be for using gabapentin and pregabalin? One of my patients is on both.
I was going to say, so you want to just save that question for the end of Dr. Rieb's talk,
We're going to talk
because she's going to
all
talk about that.
about
All right. If no further questions, thank you.
So I am Noah Alexander, and I'm a pain medicine specialist. I'm here to talk about procedural options for patients living with persistent pain. I use the term persistent pain because some patients prefer it. It implies that it's not necessarily a permanent situation, but something that can change with time. As far as conflicts of interest, so I perform these procedures at JPOC. It's all MSP covered, but that's one conflict. The other is that I'm the co-founder of an MSP covered virtual clinic called Pain Recovery, where we do group medical visits for self-management. Learning objectives. So today what we're going to try to do is identify who may benefit from these interventional pain procedures, and then we're going to understand what procedures are available and better understand the referral pathways so that your patients can access them. Finally, one other learning objective is to recognize how these procedures ultimately fit into a more comprehensive pain care plan. So Gary touched on that a little bit. That's going to be kind of a theme throughout these presentations. Medications, procedures, they're not the be-all, end-all. Pain care is complex, and the treatment is equally complex. As far as a more granular sort of outline of the presentation, we're going to be talking about the role of procedures in pain care. And then we're going to go over an overview of the interventional options, kind of like a buffet style of options that are out there for patients so that you can better understand what you can talk to your patients about and what might be available and what facilities those are available at. Then we're going to dial into spine interventions specifically with a focus on epidural steroid injections and understanding those, and then radiofrequency ablations as well and our decision making around that. Finally, we'll go into navigating referral pathways, and then following that, integrating pain procedures into that more broad pain care program that you can provide for your patients. We'll go into some case examples so that you can kind of visualize the patient in your office, what you're going to do with them, what you think that the pain specialist might be thinking when they see them in their office. And then finally, we'll finish with a summary and some take-home points. So, the role of procedures in pain care. It's one of those things that just because you can do something doesn't mean that you should do it. Anyone can give a needle. It's about picking the right patients at the right time in their journey. So procedures ultimately are tools to facilitate rehabilitation and a return to function. Like Gary mentioned, and you guys have identified, patients often get really dialed in on their pain scores and wanting their pain eliminated. I had a patient about 2 months ago tell me to cut the pain right out of him. And so that's some of these cognitive distortions and beliefs around pain are something that we kind of need to chip away at. And I don't have a magical thing to, I can't remember who said it, but what do you say to patients when they're not focused on function and that kind of thing? I think it was you, sir. And I always, like Gary, start this from the very beginning. And what I usually tell patients is that while we pay attention to pain scores, 8 out of 10, 6 out of 10, whatever, I equate it to the stock market. And if you follow the numbers day to day, it swings wildly, right? What you want to do is have a North Star. And I write this on my handout that I give to patients, like, what is something that matters to you? Is it gardening? Is it playing with your grandkids? Whatever. Going for a walk for more than 4 minutes? Whatever it might be, like, pick your North Star and let's track that. Are you getting closer to that? One common misconception that I come up with against, I guess, all the time with patients is that, the injection is going to cure me. The injection is going to cut the pain out. Finally, I've made it to JPOC. The wait list has been forever, and now I'm here. Now you've got the cure at the pointy end of the needle. And it's not the case, right? Like, it's one tool in the toolbox, but it is not the only thing. Ultimately, these procedures fit well into the more broader biopsychosocial model of modern pain care. We used to have more of a medical model. They used to cut discs just out of people. They just cut them out. Or they thought, oh, there's a problem here, we'll just cut it. The way that radiofrequency ablations came to be, originally there was a doctor, I forget his name, Rax, I think. He noticed that soldiers were getting back pain in World War I or something. So the pain is in the back, so he would stick a scalpel in there and dig around, and then the pain kind of went away. Turns out he was cutting the medial branch, but like, that was the medical model. Now we've come a long way. So this is, we will get to procedures, but this is more pain care. I have to say it because otherwise it would just hurt my soul. This is what pain care should look like today. There's 4 pillars: psychological and educational, physical modalities, medications, and procedures. Procedures is last intentionally. So first, for psychological and educational, so cognitive behavioral therapy, so courses like Empowered Relief, which is a course developed from Stanford. It focuses on cognitive CBT principles and sort of boils it down into a 2-hour session. And you can get trained on this so that you can deliver it to your patients if you would like to. Pain reprocessing therapy is based on the work of Alan Gordon in the Boulder Back Pain Study, which is based around sort of re-evaluating and restructuring your relationship with pain. If you can get certified in that too, or you can tell your patients to get the book The Way Out or listen to the audiobook. There's workbooks. It's a phenomenal resource. I think it's great. Counseling, like Gary mentioned, support. So Self-Management BC offers specific peer-led support for patients living with chronic pain. So you'll get a lay person that gets set up with your patient. It's all free. I think it's 8 weeks, and they will coach them in small groups. Pain BC is probably the #1 resource that I can recommend for everyone. It's the elephant in the room. Pain science education, so that's basically by teaching patients to understand pain, it can reduce their pain and improve their function. This comes out of work from Australia. Explain Pain is a great book. This Way Up, that is a course developed out of Australia, another really good resource, because as a physician, you can sign up for their website. Just go to thiswayup.org, you sign up. You can then waive the course fee for any of your patients. So you can only get to pick one. So I pick chronic pain. So when a patient sees me, I register them and waive the $60. But you can pick anxiety, depression, they have a bunch of courses. But chronic pain is obviously the most important. Physical therapy, and that was obviously joking, but yeah. Physical therapy, so physio, bcphysio.org is a really good website because not all physios are the same. My wife is a physio. She loves chronic pain, but a lot of physios just want to treat people that blew out their knee skiing, right? It's the same way with doctors. We all have different interests, different skills. Physios are the same. You can go bcphysio.org, area of practice, chronic pain, find someone in your neighborhood and refer your patients there. Qigong, Tai Chi, pool therapy all have good evidence. and then medications, which Launette will talk about, and now procedures. So that's my preface. So as far as an overview of interventional options, we're going to talk a little bit about myofascial procedures, joint-based procedures, sympathetic and regional blocks, abdominal procedures, dial in on spine, and then I'll talk a little bit about the future of where we're going with procedural care in North America. As far as myofascial procedures, so you probably heard of trigger points. The concept of a trigger point is that it's a taut band in the muscle. They don't exactly know what causes the taut band. They think that it's an electrochemical leak at the neuromuscular junction, but ultimately by sticking a needle into that taut band, getting a twitch response, and then injecting a local anesthetic or other substance, it's supposed to relax it. That's something that you can do in your office. It can help some patients. Platelet-rich plasma, this is a regenerative therapy not covered by MSP, but essentially you draw blood out of the patient, spin it down, that's that middle picture, and then you take off, you siphon off the middle layer between the RBCs and the plasma, that's platelet-rich. By injecting that into a joint, say, like a knee with OA, it attracts like vascular endothelial growth factor, other growth factors that help regenerate the tissue. And PRP is being injected in multiple areas for multiple reasons. The evidence, I would say, is emerging, but for the right patient who can afford it, it's something that can be worth exploring. Prolotherapy is the injection of high concentration glucose with the goal of inducing an inflammatory reaction, say mostly in ligamentous structures, to try to get them to regrow stronger. And I should also say, like Gary, if you guys have questions like as I'm going, feel free to ask now, because I think it's better when it's fresh. Yeah. Mm-hmm. So physio mostly. So physio, you know, rolling a cold, you freeze a water bottle and roll it, that kind of thing. That type of these, I think, I don't know. I don't treat a lot of plantar fasciitis. Prolotherapy or PRP would be probably the best. If you want that type of injection and MSK type of care with injections, within Fraser Health, like there's White Oak Clinic run by Zhao Yuan. They do a lot of this stuff, like MSK stuff, plantar fasciitis, that type of thing. But I would say probably one of the middle two.
I would say PRP, but if you want to do it in an office, would trigger point injections work?
No, I don't think so. I wouldn't know how to find a trigger point in the like layers of muscles in the foot. A physio probably could, but I wouldn't do a trigger point down there personally, because that's more for like taut bands in the muscle. Plantar fasciitis is going to be more of like the fascia. Prolotherapy can be helpful because you're ultimately inducing that inflammation at the enthesis where it inserts, and so by getting that inflammation there and sort of resetting things and getting it to heal might be helpful for that. But you know, White Oak Clinic is something I would suggest. Myoactivation is done, they're doing a study of it at BC Children's. Essentially what it is they do these assessments of how you move in certain planes. It's like very prescribed. And then they do very superficial needles, often along scar planes, to try and improve mobility. It's not super well studied, but BC Children's is doing a study right now where they're basically hooking kids up with those little balls that they use to make like, you know, animation characters and see how they're moving before and after treatment. Jill Lauder is heading that study, so that's something that might be coming more in the future. Joint-based procedures, so intra-articular injections, steroids. I would encourage you, if you have an interest, doing intra-articular injections, especially into the knee, isn't particularly difficult to do even blind. Platelet-rich plasma has evidence for large joints like the knee and hip. Visco supplementation, so that's like Synvisc and that type of thing. And then arthrosamid is kind of a newer injected. How many people, just out of curiosity, have heard of arthrosamid? One, yeah. So are you guys doing it at Initium yet or no?
So the reps come to talk to us and send us information.
Yeah.
But when you tell people how much it costs, they don't want to do it.
It's a lot of money. It's like $4,000 or $5,000 often. It's in Alberta. It's being injected in some clinics here in the Lower Mainland. But But yeah, it's not cheap. What arthrosomid is it's a polymer. So it is injected intra-articularly into the knee only. That's the only thing that it's approved for. And essentially with synovitis, so when you have a bit of fluid in the knee, this injected polymerizes and creates like essentially an implant within the knee. And so you get pain relief for 3 to 5 years. There was a 2025 RCT, and that's the only really big study that's been done on arthrosomid, and it showed improved function long term. So compared to steroids, kind of the same at 3 months, but then when you look at 12 months and beyond, arthrosomid won. So if you have a patient that has the means and wants to try something that's a bit longer lasting, that's another option. Radiofrequency ablations. So you can do radiofrequency ablation of any sensory nerve. So this is where we're cutting the sensory nerve. So you can do that of the knee. That's called the genicular radiofrequency ablation. The hip, that's not done that commonly, but some people do it of the hip and shoulder. And this is a way to like avoid steroids. Or if someone's about to get, say, they're waiting for a knee replacement, nobody wants to inject their knee, right? So they can do an ablation to facilitate the prehab that goes into preoperatively. So if during this you're by chance thinking like, oh, some of this stuff sounds cool, like I'd like to learn it, there's some different organizations that can help teach you. The Canadian Association of Orthopedic Medicine down at the bottom has a good course that they run, as well as they're mostly focused on regenerative stuff, but it's a really great way for family docs to get involved with this. They do have a chromic certification that's essentially like a fairly straightforward exam to better understand the material, and they have conferences and stuff. Anatomic Foundation, Sports Medicine, Ultrasound, ASRA is probably my favorite. They have a really great course out of the States, super organized, very well run. I'm a big fan. Okay, sympathetic blocks. So sympathetic blocks are typically done for sympathetically mediated pain. The classic example is going to be complex regional pain syndrome, but they're indicated really for any time you think someone has sympathetically mediated pain, which the most gold standard thing is going to be CRPS. When it's in the upper extremity, we do a stellate ganglion block, which is at C6, typically done by ultrasound. Some people do it by fluoro, but now most people do it by ultrasound. And then lumbar sympathetic block is down below, and that's for lower extremity CRPS. I just did one of those today. These things are temporary, and they can help some patients return to function, but in an ideal world, and what we try to coordinate is you want the patient to get the block and then immediately go to physio. So while the block is in place and they can move their painful limb, the physio is moving it around and getting them to do stuff. Because ultimately CRPS is treated by physical therapy and desensitization. This facilitates that. Yeah.
Opioids, and nerve stimulators, do they have any place for that? And is it done in Canada or not?
So spinal cord stimulators, yes. For refractory CRPS, they do that. The places that do spinal cord stimulators in BC are St. Paul's, that's a provincial program, and then the Island, Victoria, and Nanaimo do it, much lower volume of cases. And I'm pretty sure they will only do VHA patients. But it would be the St. Paul's program that can do it. It's a highly selective program. You need to pass, you need to meet the psychologist, the pain doctor. You get a trial implant for a week, see if it helps. If it helps, then, and you can manage the device, then you can get the full implant.
And intrathecal pump?
Not as common anymore. No. In PG, are they doing?
So we've had one of the largest intrathecal opioid pumps in Canada.
Yeah.
Program.
Yeah.
And that was because it was the other physician that was there that's now retired. It was his sort of project. He really thought it was going to be a cure-all. Since he's retired, we've only implanted one person, and we've taken pumps out of, I think, 5 or 6 people.
So kind of on the
It's
down.
It's on its way out. We're trying to get people off
Yeah.
those pumps.
Yeah.
So I think it was bigger before, I think, and then spinal cord stimulators are probably replacing that. There's some new technology coming out with spinal cord stimulators that's pretty cool. It's essentially like one of the issues with spinal cord stimulators is as the device, the probe gets closer to your spinal cord as you move, or like people aren't allowed to fish because then it gives them zaps. So now this new technology essentially acts like almost like noise isolating. So as the spinal cord gets closer, it dampens down the signal. So it's providing a lot more better functional outcomes. St. Paul's, I think, just started doing that like a year ago. But yeah, spinal cord stimulator, St. Paul's. These sympathetic blocks can be done at a variety of locations depending on your pain. So intra-abdominal, you can do a celiac plexus block, or actually that's not really, anyway, celiac plexus block for malignant abdominal pain, so like pancreatic cancer. We don't do those typically, just for anyone with obviously abdominal pain. Pelvic pain, superior hypogastric plexus block, perineal pain, ganglion impar block, and then switching gears away from sympathetics, we look at abdominal wall blocks. So if patients have like post-inguinal hernia surgery repair pain, it's often from entrapment of one of the nerves there, the iliohypogastric or ilioinguinal nerve, and we'll do a block, just sort of a field block in that area to try to reduce the pain there for abdominal pain.
How long do they last?
So it really depends. Like, I am not a big fan of them because I find they don't last that long. Sometimes they give patients like a bit of a pain vacation, and that can be helpful. If it does help, what you can do is something called pulsed radiofrequency ablation of them. Have you done many of those, Gary? Or,
I haven't pulsed in a long time, but I've been like getting more interested in like cryoneurolysis.
yeah.
Patients.
So cryo it's similar concept. It's either way. It's both of them are like stunning the nerves instead of cutting the nerves. Pulsed is, and we're going to get to that later. With continuous RF, like what we're going to talk about, you're going 80 to 85 degrees. You are burning tissue, and you are cutting the nerve. With pulsed, you go to 42, or cryo, you're going to like, I think it was like minus 100 something, minus 80. Yeah. And then you ultimately stun the nerve. You don't cut it, so it reduces pain temporarily. It's a way to reduce opioid use. With these blocks, to answer your question, they don't last that long. I think that the effect that they have when they do last longer is because we're just mobilizing tethered nerves. That's my guess, you know.
With these rhizotomies, I always wonder, does it affect the muscle later on?
We'll talk about that. I guess we're getting to it. So rhizotomy, let's talk about it in general first, and then I'll talk about that. But short answer is yes, but it doesn't matter, probably. So radiculopathy or spinal stenosis, this is where we're looking at epidural steroids. We've got the transforaminal approach, interlaminar and caudal approaches for those steroids. Non-radiating axial back pain, so if it's facet mediated, so that's the joints of the back, the only way we know if it's a facet mediated pain is to do a medial branch block. That's basically freezing the nerve that supplies the joint. The physical exam and history is important, but this is the only validated way to determine if it's facet mediated pain. With the SI joint, it's the same concept. We freeze the nerve that supplies the joint. It just happens to be that those nerves are called lateral branches. If the medial branch or lateral branch block is positive, meaning they get a reduction in their pain for the duration of the anesthetic, so usually bupivacaine, then we do the radiofrequency ablation, which is where we burn those same nerves. What if the patient has disc pain? There's not a lot procedurally that we do for disc pain. There's a saying, the disc is where good therapies go to die. They've tried to inject a lot of different things, steroids, local anesthetic, PRP, nothing has really been borne out at this point, but hopefully one day soon. Basivertebral radiofrequency ablation is for vertebrogenic pain, so that's patients that are having pain from the end plates of the vertebrae. That's something that's available currently at St. Paul's only on a trial basis. They're doing, I think, an RCT of it, but hopefully that'll become available more broadly because it seems like potentially a good procedure. Refractory pain for low back as well as CRPS and other conditions would be spinal cord stimulator. We'll talk more about the ablations in a little bit, but to answer your question, when we do a radiofrequency ablation, what we're ultimately trying to do is lie a probe a cannula, a needle, alongside the medial branch. And then we heat the tip of the cannula to 85 degrees, and that burns the medial branch. The muscle that is in the area that gets denervated is called the multifidus, which is a very small stabilizer of the spine. And so that does get denervated. And so patients that has been shown to have fatty atrophy on MRI long term. But patients that live with chronic pain without an RFA still get fatty atrophy of the multifidus. So it may be something that's going to happen anyways, and certainly someone that is immobile because of their pain, their back pain or whatever, they're going to get deconditioning of that muscle anyways. So it does get denervated, but it doesn't seem to have any functional impact on patients. So epidurals, these are just a general note on kind of the different approaches. We've got the transforaminal approach up here. Sometimes we often do a selective nerve root block with that as well. Transforaminal epidural steroid is where we go here and we just get it to flow up into the epidural space. That's a little bit of contrast you can see outlining the pedicle. That's an epidural. Selective nerve root block would be when it's just a little bit outside of that. So you're just trying to get the nerve. Interlaminar is obviously between the lamina, the classic epidural approach, like if you're delivering a baby and you're getting an epidural. Caudal epidural is through the bottom, the caudal epidural space. So how do we decide? Ultimately, it often comes down to anatomy, the patient's presentation, and available epidural fat on MRI imaging. But there are some guidelines that help guide us to determine what might be best. So the American Society of Pain and Neuroscience guidelines came out in 2022. What was surprising to me is that they didn't favor transforaminal. They said they're pretty equal. Transforaminal I thought would be better because it's more targeted. It's like very specific. You're getting right at the nerve. But transforaminal and interlaminar were very similar. They suggest doing a caudal, so that's again from the bottom, a bit more of a shotgun approach, if you can't do a transforaminal or interlaminar epidural steroid injection. Ultimately, whether you inject steroid, local anesthetic, or a combined version of the two, they all have a high level certainty of benefit and grade A evidence. So that was also surprising to me because we often do steroids, but it doesn't seem to matter that much what you're injecting. These guidelines that came out of the ASIP, so the American Society for Interventional Pain Physicians, ultimately kind of showed the same stuff. Intralaminar epidural steroids are the best studied, so they often have the best evidence just because they're the oldest. With the increased use of fluoroscopy, we can do transforaminal approaches, so maybe over time we'll get more evidence and maybe that approach will come out on top. Often in practice, I would say people do transforaminals if there's a clear radiculopathy. You've got a 42-year-old male with a L5-S1 herniated disc, pinching his L5 nerve root, causing like a clear radiculopathy. People will go transforaminal, try and get the steroid right at the site of the disc nerve interface to reduce pain. Interlaminar, if there's central stenosis or just multi-level stenosis. So that's the 70-year-old with stenosis at a bunch of different foramina, not really sure what's causing it. He's also got central stenosis at L3-4, try an interlam. Caudal if access is difficult or if they're a post-surgical candidate. So if they've had a laminectomy, we can't do an intralaminar epidural steroid injection because the surgeons manipulated that anatomy, so we can't use it anymore. So safety considerations. These things, again, just because you can do it doesn't mean that you should. Epidurals and all of these procedures have risks. This is a picture of a cervical epidural where the contrast is going into a radiculomedullary artery, so that's an artery that supplies the spinal cord. You don't want to inject that because you'll cause a spinal cord infarct. About 15 years ago, I think they almost either outlawed or essentially banned transforaminal cervical epidurals in the States because there were a multitude of catastrophic events from cervical transforaminals. Now, fast forward to today, it is not the same situation. They are much safer, believed primarily to be due to the use of dexamethasone, which is a non-particulate steroid, so you're not injecting chunks of steroid like triamcinolone, which can infarct the spinal cord. Dex, even if you get it in there, it is less likely to cause a problem. But either way, you can still cause mechanical problems, like puncturing that artery, you don't want to do it. So these things are not without their risks. So RFA's indications are facet or SI joint mediated pain, confirmed by those diagnostic blocks like we talked about. Clinical presentation that you might see in your office. So these are patients that have not gotten better over 3 months, and they've got axial or paramidline back pain, especially in older patients. Physical examination is not accurate. If you want to assess for facet-mediated pain, you can try getting them to do extension and rotation. That loads the facets. That may make you more suspicious, but ultimately they need a medial branch block to be sure. Okay, and then this is just more of a population-based study that can be helpful in your office when you're thinking about what is causing this patient's pain. So the red line is something that I drew on there. That's 50 years old. Top left over here. So we've got disc pain, most likely in those younger patients. You've got a young patient with midline back pain, it's probably the disc. You've got an older patient, more likely the facet or the SI joint, or something entirely different, like don't miss sinister causes of back pain, etc. Facet referral patterns. So like Gary was mentioning, you know, with a radicular pain, you want to see where it travels, like it travels, wraps around the leg. And I often ask, what part of the foot does it go to? If it goes to their foot, because then that's really where you can differentiate what dermatome you think it might be. If they're saying, oh, it goes to my thigh, like everyone's pain goes to their thigh. And that often can be a facet. So this is the referral patterns for the lumbar facets. And these are the referral patterns for cervical facets. The most common facets injured in whiplash injuries are C2-3 and C5-6. So you'll want to look for that type of referral pattern, sort of head and neck or shoulder and neck. Have you heard of schneck pain? That's schneck pain. This area. Pulsed radiofrequency ablation, we kind of talked about this a little bit. It stuns nerves. The reason why we use it is when there's either a motor nerve in the area that we don't want to ablate. So like in the shoulder, we'll do pulsed RFs of some of the nerves there because you've got motor nerves really close by. You don't want to burn those. And then the future, so basivertebral nerve ablation like we talked about. Focused ultrasound seems really cool. There's something called the Neuralizer that's approved in Canada. It basically focuses ultrasound beams the same way a magnifying glass focuses the sun, so you can do an ablation of a medial branch without breaking the skin. Yeah. Oh, was that just a whoa? Crazy, yeah. It sounds like something out of Star Trek. We'll see how it goes. Like the big problem, have you heard of this thing, Neuralizer? I think the issue with it is that you can't do motor testing. You can't see if you're near a motor nerve, so I don't know how they're going to get around that. Do you have any experience with it?
So last year at Canadian Pain Society, I played with it, but they told me how much it cost. I was like, this isn't going to go anywhere.
Yeah. It's available in Toronto, I know that. And then augmented reality, so they're starting to do these studies where they scan a patient through a CT and then they load it into your visor and then you can see into the patient that, and then you just do one picture on fluoro and then you can drop the needles. So it speeds things up, it's way more accurate, maybe one day. Peripheral nerve stimulators are fantastic, or they sound fantastic. They're only available in the States. Essentially, instead of doing pulsed radiofrequency ablation, say, and getting a reduction in pain for 3 months or a couple months, you implant a stimulator, and then it is kind of like an internal ductor hose for a nerve. So navigating referral pathways. These are the hospital-based programs that I wanted to tell you about. We'll focus a bit more on Fraser Health, but you've got Fraser, JPOC, as well as the interventional pain clinics. Providence has St. Paul's, VHA has Victoria and Nanaimo, VCH Richmond Hospital, and Northern Health has Prince George, and then BC Children's 360 pain program for any pediatric patients with persistent pain. Community clinics, so the bold ones are spine accredited. It's very difficult to get spine accreditation now, so only a few of them are accredited for that. Kinetics in Vancouver, as well as Canadian Pain and Regenerative Institute. And then we've got Change Pain in Burnaby and White Oak Pain Clinic and Muscle MD all in Burnaby. White Oak and Muscle MD do more of the MSK peripheral stuff. They're not going to do anything spine. Abbotsford has Initium, and then the interior has the Bill Nellum's network of clinics. Vancouver Island has Helmkin. And then it's important to recognize that only Change Pain and Helmkin can do cervical epidurals. So if you're having a hard time getting a patient into a hospital program or whatever reason, and you think they might need a cervical epidural, those are the only community clinics that can do them.
And that's private pay or MSP?
So it's the physician fee is MSP covered, but the clinics charge overhead cost because basically the government doesn't pay for the fluoroscope, the tech, the meds, anything. So the cost for a procedure varies. Most of the time, like a medial branch block, I think is in the region of $100 to $300 ish, and then an ablation is probably in the region of like $400 to $600 that the patient pays. Are they covered?
By extended? Or
No, I don't think. I've never heard of it being covered. No.
I don't know about the other pain clinics, but we don't charge for the interventions. All we charge is for the medications used. And then
Okay.
only in the setting of RF do we charge for the disposables.
Yeah, disposables.
But everything else is we do the trade fee.
Okay. So I think, yeah, Gary's saying meds aren't charged. Oh, the meds are charged.
We charge the patient.
But then so if they're getting a lumbar transforaminal, you just charge for the steroid?
Yeah.
And that's it?
Steroid, lidocaine, contrast.
Okay.
And saline, that's all they pay for.
And then RFs, you charge for the disposable?
RF, they have to pay for the disposables.
Okay.
We can't cover that in the trade fee.
Yeah.
I have
So-
a question.
Sure.
So people with spine chronic pain, where do they go for tracer help? We have no tracer.
We're gonna, that's the next slide here. Okay, so fully hospital-funded clinics include interdisciplinary as well as interventional pain clinics. So this means that we have both. We have all the physio, we have OT, we have psychology, we have psychiatry, we have self-management classes, we have a clinical pharmacist at JPOC Chronic Pain Clinic. We're also associated with the JPOC Pelvic Pain Clinic, and then we also do interventions. So as far as like a one-stop shop, I would say that's it. My bias is that I work there, but that's a multidisciplinary pain clinic that includes interventional options. Then you also have the interventional only, so these are run mostly by anesthesiologists, I think, and they'll do injections, mostly epidurals. I think ablations too, but just interventions. Like they don't have the physio and all that other support. I don't need to tell you about Pathways BC, but this is how you can find out about wait times and stuff like that. And just to circle back a little bit, again, these procedures are only a part of the much bigger whole. Pain is complex, pain is invisible, pain requires a much broader approach to its management. This is how a comprehensive pain care model would work in BC, and we're close, but we don't quite have it. The ideal pain care model would include education, movement, peer support, like Gary was talking about, self-management classes, interdisciplinary care. So multidisciplinary is where different providers work in the same environment. So physio, OT, doctor, pharmacist, all working in the same clinic. Interdisciplinary is where they work in the same clinic and they talk to each other about the patients. Psychological support, medical and procedural care. So how do you integrate some of these aspects into your office and what you're doing at the bedside? These are some programs with no cost to patients regardless of location in BC. Pain BC, again, number one, they've got everything. They're great. Self-management BC for that individual, or more individual sort of peer-led coaching. This Way Up I mentioned before, painrecovery.ca, that's my virtual clinic. Health Canada chronic pain resources are really helpful. And then for kids, the mycarepath.ca is developed by the BC Children's Program, and that's a good sort of online self-led thing. And then the BC Children 360 Pain Program is pretty close to what pain care should be. They've got all of it. It's very interdisciplinary, great program. So we'll run through some quick case examples. If people can kind of just take a stab at what you think should be done, if anything, for these patients in terms of procedures, that would be great. So feel free to just raise your hand or maybe just shout it out. So case one, 34-year-old male with an L4-5 herniated disc causing radiculopathy for 1 month. What injection would you do, if any?
No physio.
Yeah, good, physio. Awesome, that should get better. 64-year-old female, and one other thing with radiculopathy, typically it goes all the way down the leg, right? As it's getting better, it retracts. So it'll like start, oh, it was in my foot, and now it's in my calf, and now it's in my knee, and now it's in my thigh, and now it's in my bum, and now it's gone. 64-year-old female with axial dominant neck pain for 3 years following an MBC. So pain in the neck, what procedure might we consider based on what we talked about? Pardon me? You could try that. You could try trigger points or something. Typically in a patient of this age with a history of an MBC, you're thinking maybe facets. So C2, 3, C5, 6. The only way we're going to know that is by doing medial branch blocks. So probably a medial branch block would be reasonable if it's positive RF. Case 3, 7-year-old male with multi-level spinal stenosis, significant functional limitation from neurogenic claudication every time he walks. Caudal epidural, anything else? Yep, you could try a caudal. Ideally, if you have TFESI or interlaminar available, you do that. So if you can, you would go at a space that's closer to the level of stenosis. So let's say it's L3-4, you try and go at L4-5. 58-year-old male with diffuse muscular pain in both legs. Jen's like nothing. So the point, you could consider trigger point injections if this is something that hasn't gotten better. Physios will do IMS sometimes for this. Trigger points are like IMS just with lidocaine or some kind of anesthetic. 38-year-old female with severe fibromyalgia and pain throughout her body. What? Counseling, yes. Multimodal management, right? Like they don't need an injection. Now it's important to recognize that while we talked about neuropathic pain, nociceptive pain, and nociplastic pain, you can have an overlap, right? A 38-year-old female with severe fibromyalgia is still allowed to have severe, well maybe not 38, but let's make her 70. She's still allowed to have severe osteoarthritis of her knee, right? Like she might still have fibromyalgia and pain all over, but she still needs something for her knee. So we got to make sure that we don't get totally lost or blinded or have that anchoring bias to like, you're a fibro patient, you're fine. Little shout out to this diagnostic criteria. Gary shared the one that I studied for the Royal College exam and stuff. This one I find much more useful clinically. You can just Google 2019 AAPT diagnostic criteria. All they need is pain in 6 areas: head, chest, abdo, one of the limbs, or any of the limbs, upper back, lower back, for 3 months and moderate to severe sleep problems, and they have the diagnosis of fibromyalgia. It's just easier to remember, and I can ask them this clinically off memory. Summary and take-home points. So procedures can reduce pain and improve function when they're used judiciously. They assist in reaching functional goals, so try and get your patients to develop those earlier. And they're a part of multimodal care: psychological, educational, medication support, physical therapy, and movement. Thank you for your attention.
Other than like an emergency situation like cardiac arrest, what are the red flags that you would see that would make you pick up the phone to a neurosurgeon?
Good question. So the aside from cauda equina, unexplained weight loss, night sweats, fevers, that kind of thing, the thing that would make me the most nervous is acute progressive symptoms, particularly with signs of myelopathy. So myelopathy is an indication. It's like angina of the spinal cord. That's the way you can test for it in the upper extremity is something called Hoffman's sign. Has anyone heard of that? You kind of hold the middle finger like a cigarette, you flick the DIP, and these 2 fingers go like this. If you have patients with a spinal cord injury, like an established one, try doing it on them, and then you'll know what it looks like. So that is one. And then the other one would be an acute disc with acute myotomal weakness. So myelopathy, spinal cord, myotomal weakness is the nerve root. So if someone came in and they were like, I used to have, when I got referred, I had pain going down my leg to my foot. And then over the last 2 weeks now, I can't lift my foot at all. And they have a known disc. Then I'm going to be like, because they would probably do a discectomy pretty quick. Anything else, Gary, that?
So they just
Yeah.
But if the patient has muscle atrophy, what will be your best approach to these patients? Already with muscle atrophies.
So sorry. So in this setting, so if they had lateral muscle atrophy.
With the pain, I mean, yeah.
Yeah.
There is patient with severe pain, muscle atrophies, radicular pain, everything together, and plus diabetes. So already there is other causes. What would be the best pain management for them? Would be neuromuscular block or rhizotomy in this case? What it would be?
So it's hard to answer that question now. It's not seeing the patient or seeing the imaging, right? But if this is like an acute presentation, in a period of weeks, they've had, there's a asymmetry and say the size of the calf or the thigh. That's going to be when I'm going to pick up the phone and call a nurse.
And I think the reason is it's essentially that myotomal weakness, right? If you have such bad compression that it's impacting the nerve root to the point that it's been so long that now they're getting muscle atrophy, you're like, oh wow, that's motor. We care a lot more when it's signs of motor dysfunction.
Patient with myalgia paresthetica. Myalgia paresthetica.
Yeah.
If no response to conservative treatment, including medications, what is the next step?
So there's lateral femoral cutaneous nerve block. You can, it's ultrasound-based procedure, superficial. That would be the next step. Yeah, with a little, sometimes people will put in, sometimes a little bit of steroid. So the belief with steroid and nerve blocks is that it reduces C fiber firing. So the C fibers are like slow pain fibers, and steroid is believed to help with that. But it'd be a nerve block, and any of those peripheral clinics can do that. The White Oak Clinic, Muscle MD can do that. You don't need to refer to like JPOC for that.
Usually a self-limited condition anyway, it goes away.
Yeah, it usually goes away. I mean, weight loss
A
and
lot of patients like weight loss, not lose belt or lose clothes. Somebody they is operating forklift or something.
yeah,
Okay, they're sitting all day. But
Yeah.
years is going on.
yeah. Nerve block is the next step. Any other questions? Yeah.
Do you ever recommend PEA for pain, chronic pain?
I haven't done a lit review on that, but I've seen other people recommend it. It's a good question. I don't know if, Launette, you're going to cover supplements, but
Because I have some patients at pain clinics and they come back with consults. It's recommend PEA. Take 300 milligrams 3 times a day for 3 months.
yeah, I've seen some people recommend that. I just haven't done the lit review myself. That's on my to-do list because I think there's a good portion of patients that either never want to be on meds, have tried meds and don't like them. So coming up with like a supplement plan would be good. I don't know the answer to that.
My question again, a recovering addict on gabapentin and pregabalin both, how much will you be concerned about this kind of patient?
So I wouldn't start them on gabapentin and pre-gab. Like I would try to take them off.
Started by me.
Yeah, I know. I would try to take them off at least one of them. They don't need to be on both. They do essentially the same thing. So as far as the recovering addict, I'll let Launette speak to that and how that affects things. Typically, so with pregabalin, most people know this. The big advantage of it is that it comes on. It comes on much quicker. So it reaches steady state. Both of these medications need to reach steady state. I'm very self-conscious. Pharmacist? No. Where's the pharmacist? Okay.
And it's twice daily
Is he
dosing
gone?
instead of TID.
Yeah. Okay. Anyways, pregabalin comes on a lot faster, so it reaches clinical effect within about a day, whereas gabapentin takes 7 to 9 days, and it's less frequent dosing. So I kind of like that, so that patients can feel the effect a bit quicker, and especially feel the effect of dose changes. So many patients that I see are started on 25 milligrams a day of pregabalin, and they're like, oh, my pain's still there, and you need to go up. But it's nice because they go up and then they feel the effect right away, compared to gabapentin where it takes like 7 to 9 days, and these, But I would try and take them off one. Jen?
Can you tell us more about being recovered?
That's a plan. So pain recovery is a virtual clinic. So Jen is gonna just claim her conflict of interest. Jen, we're very lucky to have Jen work with us. Jen is a fabulous OT with Fraser Health. There's more information at the back, or you can talk to me. But essentially, we are a virtual clinic where we do group medical visits, all with me and another allied health, or frequently with another allied health member like OT or PT. We have a variety of self-management topics: pain science education, pain reprocessing therapy, empowered relief. We do a bunch of gentle movement classes. We do sleep. We do anxiety and stress, and how that all interacts with the pain system. And so it's all MSP covered, and it's all on Zoom. So that's what we do. No procedures. Yeah.
So I'm Launette Rieb, as was mentioned earlier, and I do a lot of pain addiction, mental health, concurrent care rehab. So that's kind of what we're going to talk about tonight, with a focus on the medication management piece. But we're going to broaden the conversation to start with. So we're going to, first disclosures, I'm getting an honorarium, as are the other speakers, for being here. I don't have any relationship with Big Pharma. I do have a CIHR grant with others that we're making cannabis use disorder treatment guidelines. I work at Actum Health, and we do concurrent care there. And I do some speaking for WorkSafe BC, all CME accredited. Great. And our learning objectives for this section of the talk is to be able to review overlapping concepts related to pain, mood, and substance use. Because a lot of our patients, if they're in pain, they have a higher risk to use substances. If they use substances, they have higher risk to develop pain disorders. And if they have mood disorders, they're higher risk of both, and either can create mood disorders. So it's all really overlapping. So you'll tend to see more of one or more of the others if you see a patient with one of the above. And then we're going to be able to explain or outline certain medications and how certain medications and substances can alter pain, sleep, and mood perception. So it's important to understand that interaction. And then outline or explain strategies needed to effectively co-manage pain, mood, sleep, and substance use. Does that sound okay? Sounds like something you might want to stay awake for? Okay, let's go. Okay, so let me start with the initial concept that pain is a primal threat response. So pain is not proportion to how much tissue damage you actually have. It's proportion to how much threat the brain is seeing this. And so it serves to alter your behavior, to either keep still, fight, or run away. So once you start seeing pain as a primal threat response, as the potential of tissue damage or the threat of tissue damage, you can see how the brain is responds. And we have millions of years of evolution to keep pain signaling alive in the brain. So it takes a lot, often, a biopsychosocial approach in order to alter that, because what we're doing is we're fighting against millions of years of evolution that's trying to keep you safe. So feeling pain, being able to feel pain, actually maximizes your chance of survival with acute pain settings. So if you didn't recognize the dog who ran up and bit you in the leg, if you didn't do something like kick the dog in the head and run away, you lower your chance of biologic survival, right? So we need pain. We have to feel that pain. But what happens when the dog has run away, there's no more dog, but your leg is still hurting? Maybe you had some local tissue, maybe there's some local nerves entrapped, or maybe there's still just signaling, or the brain is still perceiving threat every time it sees a dog because it's trying to protect you. So brain is, it's nociception or signaling until it gets to the brain, but it's actually the brain's integration of that signal that produces the pain. So once we get that shift of information for ourselves and for the patient, it really makes a lot of sense. I'm all for being able to use medications or use procedures to alter pain generators in the periphery or centrally if we can. But a lot of pain perception also plays a role in pain, and we can alter that. There's a lot of ways to alter that. So pain, mood, and addiction pathways all overlap in the nervous system. And chronic pain becomes a different disorder. So it becomes a maladaptive response to threat. So we need to help alter that.
So there's ways to coach pain to learn how to turn down the attention. Because if you're still feeling pain, but there's no dog there and the tissue is basically healed, or as much as it's going to be, it's now maladaptive to feel pain from that area. So we have to try to help with that signaling. And we want to focus on functional restoration, as has been said by our two previous speakers, instead of on pain scaling. I went to McGill University. I studied under Ron Melzack, who invented the McGill Pain Questionnaire. You know, this is before your times. But, you know, we used to have patients not only scale 1 to 10, but do this detailed, multiple page, detailed assessment of what their pain felt like. But over time, we've learned that that actually makes them focus more on pain and actually disempowers them from functional restoration. So we try only to do brief pain scaling, maybe at the beginning, and if we do a medication or some adjustment. But what we really focus on is function. Okay, that's the blurb on that. I want to bring up the concept that substance use, we're going to talk about opiates in a minute, but also alcohol use and tobacco to some degree, but binge intoxication with alcohol or steady alcohol use where you have a withdrawal syndrome can alter the nervous system to be more sensitive to pain. What the patient knows is that there is a dose response curve to numb their pain. The more you drink, the less you feel, right? And so we want to acknowledge that up front, but then also, as the alcohol comes out of their system at night, they will wake up more frequently, A, because they have to pee, and B, because their system is more activated, because it's been suppressed and it rebounds. And also, during the day, they will be more pain sensitive. So the biggest alcohol researcher in the world, Dr. Koob, has said that alcohol is actually a chronic pain disorder. So that's how much alcohol can alter the nervous system. And a lot of patients don't know about that. So it's a really important thing to share. And often their lived experience will be, yeah, they feel like horrible the next day. They'll feel achy the next day if they've gone on a bender. But what they'll say is, oh, I probably did too much the night before. And that can happen. Sometimes you fall down a flight of stairs or something you didn't notice because you were drinking so much. But sometimes it's just that sensitization the next day. The other thing that alters the nervous system that we know about is trauma. So of course, high ACE scores, early childhood trauma, adverse childhood experiences, but also, sexual assault, kidnapping. I mean, there's some really extreme things that can happen, but also more subtle trauma, interpersonal trauma that can alter the nervous system to be more sensitized to pain. Also injury, especially repetitive injury. So if you've had 3 or more injury sites and you have 3 or more painful sites on your body, you're more likely to sensitize your nervous system. And you were talking earlier about even the definition of fibromyalgia if you have 6 or more sites. But people who may have recovered really easily when they were 20 from an injury, but then they have another one at 40 and another one at 60. And these kind of all get additive. And especially if you have a few in a row, this can really sensitize that nervous system because you have so much nociceptive input and the nervous system is having trouble integrating that. Now, all 3 of those can lead to a higher chance that you will then develop alcohol dependence or other drug dependence, anxiety disorders, depression, and you're more prone to PTSD. So our patients who are drinking and drugging actually get PTSD easier, as well as if they have PTSD, they're more prone to drinking and drugging. So sometimes it's a little hard to tease out causative agents here, but it's often interwound. And then these patients who have binge intoxication, trauma, and injury are more likely to be the ones who develop chronic pain disorders. And we see that all the time in the clinic, right? These predisposing factors. So to be aware of that. So the other thing that we need to explain to patients is a lot of patients say, oh, you don't believe my pain, you think it's all in my head. Well, all pain is in your head because all experience is in your head. Just like all sight is in your head, all touch comes up and gets integrated into the brain. All taste is actually, something that the brain is processing. So all experience, beyond the spiritual and emotional and, all that, but it's all in your brain. But we know that when people have a lot of nociception coming up into their brain and they are experiencing chronic pain for more than 6 months or so, the brain starts to change. So there's chronification in the brain where the brain in pain starts to look like the addicted brain, where first there is change to the areas that code for emotional response to pain, and then there is shutdown of the prefrontal cortex, just like with the addicted patient, where that area of the brain that's for executive functioning, decision making, insight, empathy, motivation, that all starts to get blunted. So this is why the patient, you say, well, you have so much pain and you really want to be out of pain, but you haven't done any of the exercises I just gave you, and you haven't gotten off the couch, and you made decisions that, don't make any sense. But that's because their prefrontal cortex is blunted, and you have to remember that. So try to lower your own frustration. Look at Dr. Apkarian's study. If we just focus on figure A here, this is a patient with a year of chronic low back pain. His prefrontal cortex on fMRI study is way, way down in terms of function. So you burn out. You can actually have structural changes and loss of matter in your prefrontal cortex with chronic pain. And that is totally novel information for your patients. You structurally can change the brain, and you can reverse it with pain treatment. So we have to have a lot of empathy for our patients who are coming in, and we have to understand that chronic pain is a different animal than acute pain. It actually is a brain disease, and we have to treat it as such. So everybody always trying, even though the pain is still located where the dog bit you, that's where you think the pain is, it's now actually something that is generated in the brain and as well, and we need to also work on that. That's why we try to do integrated care, not just injections, just medication, just counseling, but integrated care. Okay. So the other things that can change the nervous system is that chronic pain can change the level of serotonin and noradrenaline in the brain. And we need serotonin and noradrenaline to have descending control on ascending nociceptive pathways. So that signaling that's coming up from anywhere in the body, up the spine, we have to have serotonin, noradrenaline, and dynorphin, actually, to gate it. But if you've been in pain for a while, your brain just doesn't produce as much of that. People start to look depressed, and then you can't gate the pain information. It's really nociceptive. Pain isn't pain till it hits the brain, says Dr. Apkarian, but that nociception till it hits the brain. So that's one of the reasons we use SNRIs like duloxetine, is because it provides serotonin and noradrenaline. You get better descending control on the ascending signal, and you help mood, which also changes your perception of the pain. There's lots of evidence for non-pharmacological therapy. Some of it was presented earlier. That's a whole talk unto itself. I just like this slide, even though it's a 2016 slide, and I know Dr. Roger Chu, who created this, it's just an example of, even in 2016, he's a really great internist who does meta-analyses on all sorts of topics related to pain. And what he wanted to show, these are all the positive trials, even as of 2016, that were robust, positive trials for help in different areas. So we can see that exercise leads the pack. Then chiropractic manipulation, acupuncture, multidisciplinary rehab, psychological therapies, massage, yoga, mindfulness-based stress reduction, Tai Chi. This is just an example. So when patients say, I want this pill, or this is the only thing they're focused on for pain meds, we need to really work a lot on diversifying their view of what can help with pain. So that's part of our job, is offering them a menu. Some of these things you can do group medical visits and bring in a practitioner who will help to do that. So you do it online virtually. You can do it in your office as well. You can sit and do your charts and have an OT or a PT or a yoga instructor, lead something and have a chronic pain group that meets. And that way the patient gets served. You split some of the money with the practitioner. There's ways to bring people in. Then if we look at pharmacological treatments for pain, there's the non-opiate analgesics, both acetaminophen, NSAIDs, both topical and systemic. There's co-analgesics, the tricyclics, the SNRIs, the gabapentinoids, other anticonvulsants, capsaicins, skeletal muscle relaxants, and cannabinoids. And then there's opioids, so you can see all the opioids on the list. So I'm going to go through different types of pain and different medications that work for different types of pain in a second. I wanted to point out the peer simplified chronic pain guidance summary. And what I like about this, my disclosure is that I was an external advisor on this guideline. After they wrote it up, I made comments and it went back and it got, they made changes. And that's not the reason I like it, because I had a hand in it, but it's because what they did is they looked at osteoarthritic pain, chronic low back pain, and neuropathic pain. So those are sorry, the slide's hard to see. I just wanted you to know this existed. But what they did is they looked at medication efficacy in the different 3 categories, and these are the 3 major pains we see in primary care. And then they showed how much above placebo response each of the therapies do. So they started with the evidence around physical activation, psychological therapies, and then the medication. So how much above placebo? And so you can see for osteoarthritic pain, for example, how much above placebo each of the medications help with. And so I think that that's a really nice little table to look at. And you can also help your patients, like why are you recommending this particular medication? So, okay. And you can just Google that, or you'll have my slides, so you can call that up and go online and look at that guideline and have that for those different types of pain. And I'm going to incorporate that into some of my pearls in a minute. A lot of patients are coming in they used to come in a lot asking for cannabis for medical purposes for their pain, not so much since it's been legalized, but a lot of patients are using cannabis because of pain conditions. So I just wanted to show a little bit of the evidence around that. So there was a systematic review of systematic reviews, which is our highest level evidence, by Dr. Mike Allen, who's a Calgary out of Alberta. And they showed that it's reasonable evidence that cannabinoids improve nausea and vomiting after chemotherapy and might improve spasticity, primarily multiple sclerosis, and it was mainly self-report in those patients. And there's some uncertainty about whether it improves pain, but if it does, it's neuropathic pain, and the benefit is likely small. And adverse effects are very common, meaning benefits would need to be considerable to outweigh therapy. So what does he mean by that? So the average pain reduction with a cannabinoid is 1.5 on a 10-point scale. The average pain reduction for placebo in the studies with cannabinoids was 1 on a 10-point scale. Usually it's higher, it's 2 to 3 on a 10-point scale, depending on how you do it. But that means that the average reduction is only 0.5 out of 10 above placebo for neuropathic pain. That's what acetaminophen is, and we consider acetaminophen ineffective for neuropathic pain. That's not to say some patients might really find benefit, but it's just to kind of put this in context in terms of when patients come asking. Also, the number needed to treat for a 30% reduction in neuropathic pain with cannabinoids is 11 to 14. So out of 12 patients, let's say, that you might put on it, you would want to take 11 of them back off. Yes?
Question. So, is there a genetic component of some people that would respond, like sort of super responders to cannabinoids, and others who don't respond at all? So, even though it's an NF1, not NF12, is that one that's going to respond really, really, really well? Was that any? I mean, I'm not advocating.
The studies that I looked at didn't say that one person had a massive response, but it was just to get a 30% response, which is considered usually the threshold to consider something viable to recommend as a medication. Yeah. And in terms of, there are genetics about, for example, how you, if you're valine positive at the COMT allele versus methionine positive or mixed, in terms of your risk of psychosis with cannabinoids. So it makes sense that there might be a genetic component to pain response as well. Yeah, good question. I think one day, we know that if you have a certain genetic component that you're at high risk, like 16-time elevated risk of psychosis. We also know, with alcohol, for example, that if you have a certain enzymatic pathway, depending on how you break down acetaldehyde and alcohol to acetaldehyde to vinegar and water, how you break down with those two enzymes, if you're a fast or slow metabolizer of them, whether you'll be at high or low risk of alcohol use disorder. So I think one day we'll just do buccal swabs on everybody and we'll say, hey, you know, you might be able to use cannabis and have a low risk of psychosis, but you'd have a high risk of really not feeling well and building up acetaldehyde and flushing and vomiting if you drink too much. So, you know, but you might be the opposite, right? So we might be able to have more personalized approach other than it's all bad for you kind of thing. Yeah, excellent. All right. Okay. Did that. All right, so there was a question around herbal treatments. So PEA, I as well have not read the literature on. It is like a cannabinoid-like substance without some of the side effects of cannabis. So, but I've never used it myself, but I know Brenda Lau has used it at Change Pain and put people on it. And so has some of the other pain providers. I don't know how much in favor it still is. Does anybody in the room have experience with it and have found it a good anti-inflammatory pain reliever? No. Pardon? I was just asking about PEA specifically. So no one in the room. Okay, so we're all in the same boat. So let's look at the other things on the list. So this was a really nice article that reviews herbal medications for pain treatment. And I put it up because many of our patients actually don't want any Western medicine. Also, I find that women, especially first generation patients, both men and women, but particularly women of South Asian descent and women of Asian descent, like Chinese immigrants, South Asian immigrants, really are sensitive to medications because they're very, very pure systems. The only thing they've ever had as a substance is tea, you know, and that's it, right? And so they're almost, I would almost say like just bizarrely sensitive to medicines. Part of it is they don't want to take a Western medicine, but part of it is their systems are so pure, they're just so sensitive. And so but they're more open to herbal remedies, and some people are just done, they've had too many reactions to Western medicine. So this study was a nice review, and part of the niceness about it is that they do go into some of the effects in interactions with the cytochrome P450 system and things like that. So you can see if there's drug interactions as well. But the things that have some evidence at the time this study was put out in 2021 was, you know, St. John's wort for mood, ginger is a natural anti-inflammatory, turmeric, omega-3 fatty acids can help with inflammatory. And in the article it goes into dosing. So you can look at that if you're interested. Capsaicin as a topical for peripheral neuropathy. It's hard, it's very irritating, so some people cannot tolerate it, but if they can, after 5 days or a week, then you get more numbness on the surface because it kills back the neurons slightly, just by a couple millimeters, so you can then touch the skin. I've never used Butterbur myself, so I will not comment on that, but it is part of this and feverfew I haven't used. Willow bark, obviously, ASA is derived from willow bark, but willow bark itself is quite irritating to the stomach. So like enteric-coated ASA that we make artificially is a lot easier on the stomach. Menthol, it was interesting, when I was in Boston at the International Association for the Study of Pain a number of years ago, there was the world Japanese top researcher on the whole menthol family. And what he had discovered is it blocks the TRPV1 receptor on A delta neurons. So those are your fast neurons that carry nociception, or nociceptors, and it can block dampen some of the transmission. And so he found that about a 4% menthol added to topicals is the sweet spot where you don't get too much burning, but you get some dampening of that transmission. Also the act of rubbing it in. And I always pair it, let's say, with a 10% diclofenac and a 10% diclofenac and 4 to 5% menthol. And also the menthol then is cueing the person for the pain relief that they'll get from the NSAID and from the menthol, because our olfactory cortex is our oldest cortex in the brain. It's very reptilian. So when we add a scent to something that the person then gets pain relief with, they will cue to relax and start their pain relief right away. Just like the taste. Like, how many of you take Advil brand of ibuprofen? And who always buys Advil? Personally, I do. And why is that? Is because I have a history of migraine headaches, no more since I'm postmenopausal, thank you very much. But thank God there are some good things. Thank you, thank you. But just the taste of putting Advil, because the 200 milligram tablets have some sugar in them, they're slightly sweet, and just tasting that going in and seeing the size and the shape. So this is all placebo response when you first get that response. But what it is your own brain kicking out some endorphins and relaxing you because you know pain relief is coming. So you wanna capitalize on that. Placebo is not a bad thing. The halo effect that we give because we're confident about a procedure or we're confident about a medication is not a bad thing. We want to capitalize on that with our patients. Okay, so arnica, again, anti-inflammatory, good for bruising, topically applied, and taking down a bit of inflammation. These aren't massive. It's not like applying a steroid, but it has some evidence. And bromelain is in pineapple. That's a natural anti-inflammatory. Valerian root, hops, chamomile for sleep. So nighty-night tea, brewed super strong and in small quantity. You don't want them to drink 3 cups of tea before bed. They'll be up peeing all night, so you'll do the opposite. But all of these things have some evidence for sedation. The rest of the things on that list, again, I don't know that have as much evidence, but they are things listed in the article, so you can read about it if your patient was bringing it up. At least it gives you a source. Also, pharmacists are like your best resource, because there are herbal remedy online compendiums that they can cross-check with the medications your patients are taking, which I hadn't known until about 5 years ago. I was like, you're kidding me. So, you can cross-check all of that. Is that good for a little bit of outline? And we're gonna start a case and then we'll do all sorts of medication stuff in the cases. Is that okay? All right. So let's start with Mr. B. We'll just do one case and variations on that case, because I'll present it and you'll go, yeah, right, it was so nice, it was so simple. Like, get real. So then we'll go for some other things that could have happened and what to do about it. So Mr. B is a 48-year-old HIV positive, Hep C positive male with peripheral neuropathy. He has sleep disturbance, cocaine and alcohol use disorder, both in sustained remission. So he's about 6 years abstinent. He does little activity, his mood is low, and he's angry. His pain he rates at 8 out of 10. Now the peripheral neuropathy was because he's been on HIV meds a long, long time, and he was on the early meds that gave a lot of peripheral neuropathy, and because his HIV gave him a lot of peripheral neuropathy early. So he's one of the older crew. So the meds he was on was oxycodone with acetaminophen, so oxycosat or Percocet, trade names, but we'll stick to the generic here. So 5 milligrams of oxy with 325 of acetaminophen. He was taking 6 every 6 hours for 120 milligrams a day, and the morphine equivalent, you times by 1.5 for oxy, so it's 180 morphine equivalent. And what's our kind of cautious dose now that we would like people below if possible? 90 milligrams. And we'll talk about reasons for that in a minute, why the 90 was set. So it doesn't mean you can't have people higher, but you have to ask how much good he's getting. He had no evidence of a current opiate use disorder when I interviewed him, but according to him, he's getting no pain relief. So we would consider this a failed trial of opioids, because really, you should start to get pain relief by 50 milligram equivalent, and by 80 milligrams, 80% of people should have pain relief by then. And if you're not getting that, then you're starting to go up into the stratosphere. We're not talking about acute pain, we're talking about chronic pain. We're not talking about a femur fracture or something like that. And he's also taking temazepam 60 milligrams at night every couple nights, so a few times a week, that he's taking from his wife's source. And then he's had intolerable experiences in the past with duloxetine, venlafaxine, amitriptyline. So a lot of things he calls bug pills, or he has a lot of negative terminology, and he presents very irritably, very angry. So the initial things we offer are pain education, so the Pain BC website, for example, activity prescriptions to be able to identify what he likes. So is it swimming? Is it walking? Is it socializing? Is it hobbies? What is it that he's been giving up because of his pain that he would like to re-enter and start in small ways to re-engage? And then sleep management. So cognitive behavioral therapy for insomnia is better than any medication for sleep management. So you want to start there. And then mood management, we offered the Bounce Back program. Again, these are online modules to be able to do that. And then for his oxy, I tapered him off. He wanted to go super fast. When I said, obviously this isn't working, it's a failed trial, he was very agreeable and he really wanted it quickly. Now really, opiate tapering, we should come down like 10% or so every, week to 3 weeks, 4 weeks if they're really hypersensitive and been on for decades. But because he wanted to come down faster and I was going to see him frequently, I said, okay, let's start, especially at the top. We can sometimes come off faster and then slow it down later. So he actually chose, again, to come down by a quarter. We did it by 1 tablet every 4 days about, and then by a half a tablet every 4 days when we got to a lower dose, which I'll show you. And then we titrated him on to gabapentin. And that's because gabapentin helps with opiate withdrawal and it helps with neuropathic pain. So we began just with an evening dose of 100 milligrams so that he doesn't get over-sedated and reject the medicine. And then I increased him every 4 days until he was at 300 milligrams at night. And then I began titrating up his daytime doses by 100 milligrams until he was on 300, 3 times daily to 4 times daily. Now I know most neurologists and pain specialists will titrate vastly faster than that, but I find I don't like losing patients to the drug because they get over-sedated, so I tend to go a bit slower. And so I can, if you get up to 2,400 milligrams a day and you have no response, you should take them back off. Because if you go up above that, you actually don't increase blood levels that much. You start to get this flattening out of the blood curve. For some patients, they still will get benefit, and that's okay. But if they are plateauing with their benefit or they have no benefit, you need to bring them down and off. And again, it's an anti-epileptic. You have to titrate up and taper down. You don't need to take a year to do it, but you just shouldn't stop abruptly because there have been cases of seizure, especially if people have any sensitivity. Then what do you do about his temazepam? He's not getting it from a legal route, really. He's taking it from his wife. But in reality, if you look at married couples, at least a quarter of them will share medication over a lifetime of some sort, like in the reality. So you have to realize that this is maybe not so pathological when you find it out, but you need to deal with it because he's probably rebounding because he's doing it every 2 to 3 days. So he's probably kind of, his neurochemistry is going like this. So you can choose, you're perfectly in your rights to choose not to prescribe temazepam, but I think that for me, that I would help stabilize him more if I actually choose a dose that's a little lower than what he takes on a binge and then make him take it steadily and bring him down because he's just too volatile with it. And so that's what I chose to do. You can use diazepam or something else that's longer acting. And then nortriptyline may help with his neuropathic pain and be better tolerated for sleep, but he declined. He'd heard about that and he wasn't going to have any of it. He was quite cantankerous. So you can try lemborexant. It's an orexin inhibitor, 5 to 10 milligrams a day, but it's expensive and a lot of people can't afford that. But if you want more sedation, you can go to quetiapine. There's some early studies that it can have some pain benefit. They're small, ratty little studies. But because quetiapine was off-label, At the time these studies were done, there was no funding to do big studies on quetiapine. So 25 milligrams at night helped him sleep, and I titrated him up and I tapered him down off the temazepam. And then I offered him topical capsaicin, which could help with his peripheral neuropathy, but he declined. He really wasn't into any possibility of any more pain, even briefly, for benefit. So topical phenytoin, again, at International Association for the Study of Pain, I went to a talk on topicals. The world topical expert was there, and he uses phenytoin 10% in a fatty base, like cold cream, like really, really fatty base. And he said it sits on the surface of the skin and the neurons just suck it down. And so if it is a peripheral neuropathy, it will help. And you will know within an hour in the office. So he keeps a jar in the office and he tries it in the office. If it doesn't work, he doesn't prescribe it. But about 1 in 4 people with peripheral neuropathy, this will be, a saving grace for, which is really worth it. You can just keep that on the table. So I use that as a trial basis quite a bit. And that was helpful for him. So the result is that he had better pain control, less irritability, sleep was still a challenge, but it was improving with time. He and his wife were able to socialize more with friends. So his function had improved, his pain had come down, his sleep was better. So that's a good outcome. But we had to kind of multi-manage all sorts of stuff going on for him. Yeah?
Just a quick question. When you were tapering the temazepam,
yes, tapering
did you wait
temazepam.
until you maximized the gabapentin? Or did you start tapering the temazepam as you were increasing the
good question. So the question is, for those at the back, did I start to taper the temazepam or did I get him up on a good dose of gabapentin and then start to taper him? I actually was doing it concurrently because I didn't want him to get too used to that temazepam, but if he had been on temazepam for a while, I would have done exactly what you said, which is get the gabapentin up and then taper. Because I love gabapentin, even though it has some nasty side effects, but pregabalin even more if they can afford it, because it's easier to dose twice a day and it works faster and the milligrams is lower. I know it doesn't work with moles and everything, but the client often psychologically feel better if they're taking fewer pills and it's lower milligram strength. They bulk at these high milligrams. So what you want to do is not only can gabapentinoids, pregabalin and gabapentin, help with opiate withdrawal, which he was having, it can help with benzo withdrawal. So we use it all the time in addiction medicine for opiate and benzo withdrawal. Yeah. So that's why he was comfortable and able to come off. Yeah.
So just like there's a number of medications.
Yes, number of medications.
How many changes are you making at any one time?
So it depends.
Very resistant to me.
Right.
More than one change at one time.
So this guy, I was as the consultant, not the family doctor. So I could make a lot of changes at once. Yeah, so I got in and I was...
But aren't you worried that there's a complication?
Yes.
What?
Yes, good question. So when I work in my pain clinic, I do things more one at a time. I was an addiction medicine consult in the HIV clinic and the immunodeficiency clinic at St. Paul's. And I was seeing all these patients that had viral loads of 0, but the docs had been giving them opioids and stimulants and benzos for years because they thought they were all going to die, and now they're not dying. And so all these people are on all this stuff. And so I was brought in for 3 years to kind of clean house, basically. So I spent 3 years going through their patient roster and going, yep, let's bring him in. So I didn't have time to waste, I had a lot of patients to see. And he did super well. But in my clinic, you're right. I initiate, like the psychiatrist is the one who wants to start 3 or 4 meds at the same time. And I'm having to train him 1 med at a time because we don't know what the side effect is or, if they have a trouble with it. So thank you for bringing that up. It depends on context and what you're doing. So let's go, any other question? Yes, before we go through scenarios on this, like variations on the case.
This person who has been on opioids or diazepam,
Yes.
you are starting gabapentin at 100 milligrams.
Yeah, just tiny dose. Right. It's almost a placebo dose. And
You were tolerate 300 milligrams easily, no?
yes, in his particular case, but he's rejected so many medications and he's so pissed off at the world. Like he swaggered in, he was ready to punch anybody in the room. And he'd been a mean SOB his whole life, So I was gonna treat him with kid gloves. Like I did not want him, I knew this med was gonna help him. And I did not want him having a side effect right away and rejecting it. So I started with just 100 milligrams at night and gave him some temazepam. Oh, that was pretty good. And he's feeling better because he's not swinging in and out of withdrawal, right? So I had to find a hook in with him. And then we start to manipulate the meds. Yeah. Yeah.
For acute pain,
Yeah.
I use hydromorphone, Percocets, and things like that.
Most of the time I don't for acute pain even, but it depends on what they're having.
Like
But yeah.
wrist fractures or compression fractures.
Yeah, most
7 days.
fractures don't need opioids. Yeah. Yeah.
For chronic pain, I never prescribe an opioid.
Right.
Am I on?
No, I think
evidence
the
based on
evidence
that?
around opioids for persistent pain or chronic non-cancer pain is that in the vast majority of cases, you make people worse in the long run. And we're going to talk about opioids in a minute, about what they do and some of the problems. So I think you're right in general, but if someone has been living with very severe chronic pain experience and they have been doing all the multimodal things and they have not been working, for certain conditions and if they have certain conditions, sometimes adding a low-dose opioid might be part of that regiment of care. I don't think it needs to be off the table completely, but you have to use it rationally, and it needs to be in low dose and in a dose that doesn't hurt them, and it depends on their history and background. A guy like this with a background of cocaine addiction and blah, 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 he's really high risk to put him on opioids as a potential, because he's much more likely to get dependent and then go to the street if you cut him off. Yeah, and have an overdose, right? So he would be a very high-risk person to use opiates with.
But once you start, you're on it forever.
No, not necessarily, but it depends on what you're doing. I mean, most of the guidelines now, they say under 90 milligrams a day. If you're over 65, it should be under 50 milligrams a day. We wrote guidelines for older adults, those 65 and above, for opiate use disorder, so I led that guideline nationally. And we did prevention as the first part of that guideline, so 50 milligrams or below for older adults. But as you get older, into your 80s and 90s, it needs to be lower than that. So I don't know, for our other two speakers, would either of you, Jared and Noah, want to comment on the use of opioids for chronic pain? There are many kinds of chronic pain, but
So generally,
like never or occasionally?
I was going to say, I would probably side with occasionally.
Yeah. I'm in the rarely category. Mm-hmm.
I wouldn't be opposed to a trial.
Right.
The guidelines that you commented on. And
Right.
Like I think up to 50 morphine equivalents is a fair trial, and if
Right.
there's a benefit, and again we talk about benefit not just from pain score, but from a functional
Functional benefit, right.
then I would probably say it's worth
Right.
keeping on that medication or optimizing it, whether it's going up a little bit
Right.
or down. But I strictly prescribe as much as possible, like within those guidelines.
Yeah, okay, so I'm just going to repeat what you said, that rarely or occasionally it might be beneficial, but you do a trial up to 50 milligrams, and it needs to show not just pain benefit, but functional benefit. So trying to stay within that. And I would say, if a patient, there are patients who can't take nonsteroidal anti-inflammatories and who can't take TCAs and can't take because of cardiovascular risk. So that might be someone who, and let's say they have a severe inflammatory progressive condition. It may not be cancer, but they have some, you're seeing joint degeneration. They're having such trouble walking, blah, blah, blah. I have a friend who's a physician with severe RA, and she's had multiple joint replacements and everything. And she sometimes, during her flare, will go on a very, very, very low dose of opioid because she can't tolerate. She gets GI bleeds if they put her on an NSAID, So I think, there are cases in non-cancer pain where you might want to do it. Yeah, Noah.
I'm in the basically never can.
Mm-hmm.
So I've only ever prescribed opioids when I was working in the emergency room.
So Noah says he's in the never camp. He only prescribes opiates in the emerge.
And that view may change. I think my
The unicorn, yeah.
that you are thinking about doing.
Rare.
Like, and
Yeah.
I think, like Launette was speaking about, and Gary and myself, like, there's so much more stuff to pain care,
Yeah.
all the pain science, exercise, like gentle movements,
Right.
meeting patients where they're at as far as their movement, like there's so much stuff we can do with opioids. And it's not, like, in 10 years we might be like, oh, actually this amount of opioids
Yeah.
is good. But I just think.
So much we can do for beyond opioids.
Very wary to start them.
Yeah.
I had one consult maybe 2 months ago at JPOC that was for opioid use from a family doc, and they were like a new family doc. They were nervous with this patient. They got handed down legacy patient. She was on like 5 milligrams of morphine that she took every 6 weeks for some rare gallbladder thing.
Right, 5 milligrams of morphine every 6 weeks.
She's like, I avoid
Yeah.
hospital admissions. We're like, perfect.
Yeah,
No problem.
that's a really great example. So sometimes when I do prescribe, which is very rare, is something that's episodic, where there's an exceptional circumstance where either they have to do a certain thing that they need it for, and so they're not going to get physically dependent, or they have a flare of a known condition that's rare. Yeah.
Okay, so I have another question for you. So if you have a patient that has very severe chronic pain,
Right.
they can't take gabapentin, they can't take Lyrica.
Right, if they can't take the
What's
gabapentinoids.
your thought process on using something like Butrans, which is like a
Yes,
partial agonist?
thank you. So, excellent from the pharmacist in the group bringing up Butrans. So buprenorphine comes, most people are familiar with it in the form of Suboxone, right, to treat addiction. And unfortunately, many patients have heard of that, so they're not into it. But there is a patch form, which the pill form is approved for treatment of opiate use disorder. It was actually invented as a treatment for chronic non-cancer pain, but OxyContin was coming out the same year, and they knew that they wouldn't be able to compete because buprenorphine is a partial agonist, so it stimulates and blocks the receptor. So instead, they market it for the treatment of opiate use disorder, clever, and have made good money that way. But there is the only buprenorphine that's authorized for pain is the Butrans patch. That doesn't mean we can't use Suboxone off-label, we do it all the time. But the patch is really great. So when I do find someone needs chronic care, if their morphine, the lowest patch with the Butrans patch, buprenorphine, is 5 micrograms per hour. That's equivalent to approximately 20 milligrams of morphine. In reality, it's anywhere from 10 to 20 milligrams, but if you look at the monograph, it says 20 milligrams, but if you look at the studies, it's actually 10 to 20 milligrams. So anyway, it's harder to start it on an opiate naive patient because this will be too strong for them often. But if they're not opiate naive, let's say their Tylenol 3 has, acetaminophen with codeine, to use the generic. Tylenol 3s have 30 milligrams of codeine, and that's worth about 3.5 milligrams of morphine. So to 4 milligrams of morphine, something in that category. So let's say they're doing 5 T3s a day, then a Butrans patch would be spectacular. And what we know so the next strength patch is 15, then 20, 5, 10, 15, and 20. So when you get to a 20 so I titrate them up and titrate down the other meds they're on. So when you get to the high strength patch, that's up to 80 milligrams of morphine replacement for Butrans. And so it's so good because it's changed once a week. In reality, it falls off after day 5 if you look at the pharmacokinetics. So sometimes I change it every 5 days. It's hard to get insurers to pay for that though, but that's really the pharmacology of the drug. But you get steady state, they get pain relief day and night, and because it's a partial agonist, it's virtually impossible to overdose on. They don't get the same degree of respiratory depression at night either, so it's great if they have sleep apnea and they have to be on an opiate. That's buprenorphine is the one you want. So I personally use the Butrans patch, but it's expensive, and a lot of companies won't pay for it. WorkSafe pays for it if I write the script. So that's how.
Yeah, that's what I was going to say. It's not a benefit under pharmacare.
Yeah, it's expensive. And it's not divertible because you have the patient bring back the used patches. So all that worry about are they taking it or blah, I mean, it's not to say someone in the family can't put it on instead of them, but basically you can't sell your patch and get it back and return a used patch very easily. Yeah, so that's a great thing.
So what we used to do was, at least when we were using the transfer,
Yeah.
admit the patient
Oh.
and then give them. Then see, because sometimes we, for 2 days, and see they're tolerating and then send
Oh,
the
right,
patient.
yeah.
But here in outdoor,
Yeah. Well, you can also have, like, sometimes the pharmacist can sign, like,
I've seen the, like usually older people.
but you can see them fall down. Yeah, you have to be very careful with older adults in general.
They are the ones who need the most. For
Yeah.
example, the
Because, you know, 5 microgram patch is 20 milligrams of morphine a day, which is a lot if you're opiate naive. So I'd never start a patch on an opiate naive person. But you can't, they say you can't cut the patch, but really patches you can cut. You can use a little pink tape on that open edge so there's no bleeding. I mean, you're really not going to change the matrix. It's a lot of caca to say you can't cut the patch. So, you know, at least, you know, is that okay to say? Yeah, okay. All right. All right. They just make more money because you have to. Yeah. Okay. Let me run through some other scenarios, like what if this guy, okay, that might make it a little harder. So what if he was actually binging on alcohol and benzodiazepines when he came in? He wasn't just in recovery. So in that case, the high dose of opiate he's on, along with binge alcohol drinking at high level, and binging on benzos at high level, put him at really high risk of an overdose. And the first suggestion should be residential care in that setting, because he's really at high risk of death, but he doesn't know it because he's been doing this for a while. So how I convince patients is, you know, I say, well, I know you've been doing it for 6 months and you haven't died yet, but just think how your wife will feel if you die in the night and she wakes up with a dead body beside her. You know, it's a real bummer. Like, it's really, really a bummer, and it takes a while to get over that. You know, and then they kind of get the image, and then it's not so funny. Like, it's funny, but it's not, like, I just play with them a bit. And also, even if they don't go to residential detox, they then understand how serious it is and how the urgency to get down on these medicines. How are we doing? Oh, okay. I'm just going to whip through these cases then. We want to let them know that opioids are both ineffective and unsafe in that context, and so we need to taper them, and that speed depends on the setting and the safety and how willing he is to work on the other things. What if he had requested more opiates instead of less? Yeah, it works a little bit, that oxy, but I think if you just give me more, you know, it'll be better, right? And I have to chew my oxy, you know, in order to make it work, because they're turning it into really short acting when they do that. Like, but if you just give me the right amount, doctor, it wouldn't be a problem. So I have to explain to them that other medications are first line, and they need to be tried in sufficient doses, that we need to explain that opiates have risks, respiratory depression. I often go for, in guys, testosterone suppression, you know, sexual dysfunction, you know, something that might make a difference to them. Explain that why it's considered a failed trial of treatment. He's on 3 times the dose that we would need to let us know if it was working or not. It's not working. So you have to really sell it, and you got to do it in a way that doesn't piss them off, you know, that cajoles them instead of pissing them off. Okay? So what if he had some pain relief and increased function with the oxy, but was unresponsive to all other medication categories you tried? So he got some benefit, but everything else seemed to tank on him. So what would we do? What would we do about the opioid if it was actually benefiting? And we'd tried every category of pain, neuropathic pain med we knew. You might keep him on it. So let's see how we might do that. We might trial a long-acting tamper-proof oxy, like Oxy Neo, because this guy has quite the history of addiction, right? You want to make sure he's actually, do urine drug screens, make sure he's taking it, right? And put him on Oxy Neo so he can't grind and inject it. Is that the flash of light? We have 15 minutes, so we're going to get out of the theater soon. Then we want to trial once daily oral morphine formulation might be a possibility, like Cadian, which could easily be switched over to daily witnessed ingestion if he got into trouble, like his urine drug screen showed cocaine or something, he's starting to relapse. And then we could trial buprenorphine. So the main thought here is to convert him over to buprenorphine. We know from Dr. Deitch and Deitch, husband and wife team study, when they inherited, it was an American couple who inherited a whole bunch of patients from a pill mill in the United States, where in the US, the marshals come in if they don't like the prescribing practices of the doctor, if they feel like they're, and the doctor can go to jail in the US for prescribing. It's a little different here in Canada. You can get your license pulled, but in the US, they'll put you in jail. And so this doc had gone to jail, and so this other team of docs had inherited all these people who, for pain reasons, were on enormous doses, hundreds or thousands of milligram equivalent of morphine. And so they converted all of them over to Suboxone, so to oral sublingual buprenorphine. And their pain scores dropped dramatically. So it was a really interesting, like 80% of people had improved pain, dropped by 50% or more. So it was quite a dramatic thing. And part of that is we think that buprenorphine, it not only binds to the mu opiate receptor, sorry to get geeky for a minute, but it also binds to the kappa receptor, which is another opiate receptor. And we think that is involved with the development of hyperalgesia with opiates and some neuropathic pain. So it seems to bring that down, and they get this stability. So, and also just any kind of opiate rotation sometimes brings people's pain down. So it's both factors could be playing a role. Okay. So converting to buprenorphine. So what if he had signs of an opiate use disorder? So what if he was grinding and injecting his meds because you're such an asshole and haven't prescribed the right amount for him? So what would we do then? Yeah, you could let him go, but let's help him. Opiate use disorder is a diagnosable disorder. It's treatable, doctor. So let's convert him to opiate agonist treatment with buprenorphine, methadone, or slow-release oral morphine, whatever he'll buy into. Buprenorphine is our #1 choice for all the reasons I mentioned. We can use co-analgesics for breakthrough pain, not opiates. What drives me crazy, and I saw a person today like this, so I was driven crazy, is docs who give, like, somebody's on a long-acting like methadone, but for breakthrough pain, they get a short-acting opiate of a different type. This makes no sense pharmacologically. So it just drives me crazy. So the patients who say, oh yeah, I'm on methadone for my addiction, but I'm on hydromorphone for my back pain, and I'm on oxy for my headaches. So I see this. And then I'm on, I'm on rails, I'm snorting my rails, my Xanax to, go to sleep at night. So, okay, let's try it a different way. So we want a co-analgesic that is not an opioid. So when you have breakthrough pain, I tell them your opiate receptors are all full. Yeah, I can give you a short-acting opiate. What's going to happen is above your opiate-induced hyperalgesia, you're going to pull your little head up like a little porpoise for a moment, and then you'll dive back in. But you just sensitize yourself over and over by doing that. So for severe acute pain, when they're on opiate agonist therapy at high potency, you can use a short-acting opiate very temporarily, but that would be like if they're hospitalized with a bad break or something like that. It's not a long-term thing. Urine drug screen them more frequently and then add counseling support. So here are my pearls. For musculoskeletal pain management, we want pain education as the best evidence to help alter pain perception and function. Teaching people about pain as a threat response is super important. And then activity-based treatments are vital, like pacing, stretching, deep relaxation, hobbies, and socializing, all change the brain's perception of pain. Then oral NSAIDs and a proton pump inhibitor to protect their stomach, bringing their GI bleed risk down from 6 to 2% usually. So let's say ibuprofen and rabeprazole for an example. Topical NSAIDs like diclofenac 10%, menthol 4%, and PLO. Then SNRIs like duloxetine, and remember that it's serotonergic and noradrenergic at a starting dose, whereas venlafaxine, you have to crank that up to about 225 to get the noradrenergic effect. So Duloxetine is better for low-dose pain control because you need the noradrenaline to get that pain control. Sorry, I know it's getting late to be geeky and medical, but there you have it. And then the anti-inflammatory diet that we talked about with vitamin C, vitamin D, turmeric, bromelain, purple veggies and berries, low sugar diet, and then reducing or stopping alcohol, nicotine, and opioids if it's appropriate, and you can help them with that. And then opiates are not indicated for musculoskeletal pain in general, but if they are used, keep it below 90 and below 50 in older adults when possible, and consider buprenorphine. And help your patients find joy again. I sometimes write that on prescription pad, is like, name me something that you found joyous, and I want you to go after that, because all life becomes misery at times. So for neuropathic pain, the clinical pearls are gabapentinoids. Pregabalin is easier to dose and titrate than gabapentin, so start low, and it's SNRIs. The venlafaxine, as I mentioned, was serotonergic at low dose. For TCAs, I usually start with nortriptyline instead of amitriptyline. Nortriptyline is less anticholinergic. It'll give less dry mouth, less postural hypotension and stuff like that. And with opioids, if you look at the Cochrane review, opioids are not helpful for neuropathic pain, which is another reason I would tell that patient in this example that he has neuropathic pain. And like their study on oxycodone in the Cochrane review shows it's ineffective for neuropathic pain. And it's not to say 100% that's true, but for the vast majority of people, we don't use it for neuropathic pain. Unlike the patient I saw today who came in with 360 milligrams of opioid on board, morphine equivalent, who had neuropathic pain. But anyway, topicals are useful for peripheral neuropathy only, like phenytoin 10%, lidocaine 10%. If I use lidocaine, if they're just about to get into bed, let's say, or put on a glove or dressing, but don't use it if they're going to cook or handle hot items. And then capsaicin is good for post-herpetic neuralgia, but it really burns like crazy. I'm going to pass on the because it's getting late. I'm going to pass on all the CRPS tips, but I've included tips that are in the slide. It's just a rare disorder, so we see it, but I don't know how much you guys see it. So I'm just going to pass on that. But like bisphosphonates, like alendronate, is really one of the best medications to treat, or it can be an IV bisphosphonate. Some prednisone early on. DMSO cream has some evidence, not as robust as we thought at the beginning. And then there's interventions that you already went over today, the blocks. And my sleep management pearls are to screen for sleep disorders, obstructive and central sleep apnea, restless leg syndrome, periodic limb movement disorders, nightmares, night terrors from trauma, sleepwalking. A lot of times people don't get asked anything about their sleep, and that can be a real difference if you can manage these things. Cognitive behavioral therapy for insomnia has the best evidence. And then lamborexant and other orexin antagonists are well tolerated. TCAs, antidepressants, nortriptyline I start with. But also I use trazodone. It has less erectile dysfunction. In fact, you can get priapism with it. Very, very rare. But so that's why I would use that. And then antipsychotics, antihypertensives. Prazosin is the only medication approved by the American Sleep Society to treat PTSD-induced nightmares. It works like crazy. So 1 milligram, and you can work them up over a few weeks up to 6 or 7 milligrams if needed, but just 1 or 2 milligrams is often highly effective. It's an alpha blocker. And then Z drugs only give about 14 minutes of extra sleep beyond placebo. The thing with benzodiazepines and Z drugs is the patients, if you look at their sleep architecture, their sleep studies, it just sucks just as much basically. But what happens is it's an amnestic, so they don't remember in the morning that they've been waking up at night. So the patient has a perception of a vastly better sleep. But if you look at the sleep study, it's not that much better, and it's maybe 14 minutes longer than placebo. So we don't like to use them long. Okay. And then for mood management, exercise, stress management, mindfulness, and then concurrent pain issues, you use an SNRI. If it's mood alone, it's just an SSRI. And if it's bipolar, obviously, you'd want to stabilize that with lithium, lamotrigine, or Abilify. And for opiate management, only 1 in 7 to 11 people are opiate responsive. And that's a shock to the patients and to doctors. So only 1 in 7 to 11 will respond to opiates. And what that means is they'll only get about 20 to 30% relief. And so we really need to go up to about 50 milligrams if they're not getting relief, bring them down, and at most about 90 milligrams. And we want to use a different, using a different opiate just for breakthrough is not really wise, and we want to use short-acting opiates for breakthrough in the same category if you're going to use a breakthrough med, but that shouldn't be a long-term strategy. I also, just from a pharmacological point of view, want to point out that tramadol and codeine, both, about 10 to 15% of the population cannot metabolize it to its active metabolite because it goes through the cytochrome P450-2D6 system. And so sometimes when you crank somebody up on, let's say, T3s or Tramacet and they're not getting a response, it's because they're a non-responder. And so when you start a new opiate as a trial, you have to start at the beginning, at the bottom, and not just convert. And then we talked about buprenorphine already. So I'm not going to talk about my pain studies that I've done showing that pain can recur to old injury sites during opiate withdrawal, which is a phenomenon we identified and published in Pain. And we then went on to do a prevalence study in the Downtown East Side and show that there's a lot of it going on that's driving opiate use. So just to talk in the last minute on safety. So medication review, I've got 1 minute left. Medication review, daily witnessed ingestion, callback for pill counts, bubble packing, safe storage discussion with locked storage at home, patch return policies, overnight oximetry if they're exhibiting any signs of sleep apnea, and then having an naloxone kit. Everybody who's prescribed an opiate should have an naloxone kit with them, even if it's for pain. And that's, again, signals to the patient that that's important, and their bed partner needs to learn how to use it too. So half the time people overdose, it's actually not the person the opiate was prescribed to, it's someone else in the household who got a hold of it. So we need to be conscious of that. So in summary, we must co-manage pain, sleep, mood, and addiction issues. We must focus on non-pharmacological and non-opiate treatments and choose non-addictive and minimally sedating meds when possible. And if an opiate use disorder exists, we want to convert to an opiate agonist treatment with buprenorphine, methadone, or slow-release oral morphine. So there you go. You survived the evening. Any last question before you all escape for your well-deserved sleep tonight?
I have one question.
One question, yeah.
Do you deal with a lot of restless leg syndrome that people with opiates?
Restless leg syndrome. So I don't deal with too much of it, but clearly if it's happening, it can interfere with sleep cycle and with their perception of pain and mood.
So if you do, for example, like you check their ferritin levels.
Yeah, you check their ferritin. Yeah.
Would you be more inclined to be using, like, say, Lyrica or gabapentin?
Yes. Yes.
Okay. But not
Pramipixole or something. Yeah, I'm a little more hesitant with that.
Yeah.
So I would refer before I would, to a sleep clinic before I'd provide Pramipixole. But I definitely use the gabapentinoid family. Yeah. But you do check their ferritin because if they have iron problems, that can be a source of both periodic limb movement disorder and restless leg syndrome. Pardon? Yeah, vitamin D levels as well. Yeah, they can have vitamin D deficiency, right? Unfortunately, periodic limb movement disorder can be a warning sign for pre-Parkinson's. So it does have to be monitored a bit, right? Yeah. Okay, great. Thank you so much for your attention.